Annual Bucksbaum-Siegler Institute Symposium. So we'll get started in just a minute. Please, everybody, grab lunch, have a seat, and welcome to the symposium. So I'm very honored today to introduce our keynote speaker, Dr. Stefan Kertesz. Dr. Kertesz is the 24-25 recipient of the Bucksbaum-Siegler Institute National Award for Clinical Excellence. He is a professor of medicine at the Heersink School of Medicine at the University of Alabama at Birmingham, and a physician investigator with the Birmingham VA healthcare systems. He trained in internal medicine and addiction medicine. Dr. Kertesz began his career as a frontline physician with the Boston Healthcare for the Homeless program in 1996. Since that time, he has maintained a sharp clinical, educational, and research focus on enhancing healthcare delivery for populations at high risk of receiving poor care in mainstream healthcare systems. His research has included a long-term interest in care for populations experiencing homelessness, including housing and primary care. He's also led an advocacy and research focused on the care of patients with pain, disability, and a history of long-time opioid receipt.
Actually,
Dr. Kertesz co-hosts a podcast on becoming a healer with Saul Weiner, author of a book by that title as well. And Dr. Kertesz says he has drawn inspiration from Dr. Albert Schweitzer, who wrote, "I should make my life my argument." Dr. Kertesz's keynote address is titled Homelessness, Healthcare and Me, Searching for the Right Question. Please join me in welcoming our 24-25 receiver of the Institute's National Award, Dr. Stefan Kertesz.
Thank you very much for that kind introduction. Thank you for the people here who are in this room. I want to make sure, am I easily heard here? Good. And I want to say thank you to the people, including friends and my own father, who has joined us on Zoom. This matters a lot to me, as I'll explain. I particularly want to thank right up front the two individuals who nominated me for this award. First, I'll thank the Bucksbaum-Siegler Institute, as well as Dr. Carlos Estrada at University of Alabama at Birmingham and Dr. Adam Sifu here. Carlos is shown in his element teaching there. I shot that photograph with real film at a Society of General Internal Medicine meeting. And then Adam is shown in a beautiful shot I pulled off the University of Chicago website. So a few disclosures in case this was a CME talk. I'm not sure it is. I have some health-related stock in Thermo Fisher and Dexcom, not related to the content of this talk. I get some royalties for the Healthcare for the Homeless chapter and the up-to-date reference. The Veterans Administration required that I submit a form to approve that I give a talk, although and that has some BA work in it. They did not ask to review my slides, and anything I say here is my view and not that of any federal agency. Let me state up front my aspirations for this talk, which is what you will know, what I hope you will feel as you walk out. And I'm thinking both of my colleagues in medicine and in allied health professions, and perhaps most importantly, people who are considering or are in the process of entering the medical profession. I want people to know that understanding our patients' hopes and experiences can ground our clinical work and help us develop better care. I want people to know that seeing our own flaws is part of growing in medicine, even when we cannot shed them. I want people to know that some flaws can be calibrated into strengths, and I'll tell my own story. And I want people to feel that any of us can make a difference, step by step. And there's those images at the bottom of the magnifier, which is an examination of the world, and of the mirror, which is the examination of the self. So I'll be bringing scientific and personal stories, and either this will work or you will leave this talk feeling you are in a fugue state going back and forth between the two. This place, University of Chicago, matters to me immensely. The photograph you see is of me in 1984 as a freshman at the U of C, probably walking through the quad. I can't figure out which building. But this talk cannot be like any other that I would give precisely for this reason. It's a unique opportunity. My own story is connected to what I hope you will walk out of this room with, or out of the Zoom space with, or for those who listen to this in the future. But it is a question, how do you craft a talk that combines personal elements and research? And I asked for advice. And a person I strongly respect said, you know, you're going to be speaking at the school that matters to you. Doesn't the University of Chicago have a motto of some kind that you could use? And I said, well, it does. I'm just not sure how to give a talk called Where Fun Goes to Die. I mean, it's a thing, but does it work? And she said, no, but don't they have a real motto, like something other than that? I said, oh yeah, the thing inside the seal. They have that as well. Crescat Scientia Vita Excoletor. That is the actual motto of the place. Let knowledge grow from more to more, and so be human life enriched. So we'll meditate for just a moment on that motto, which I think does connect to what I wish to talk about today. The vibe on let knowledge grow from more to more, the vibe is incremental. It's not supersized. It doesn't portend a revolution. We might not all be future Nobel Prize winners, which this place brags about incessantly. We might not all be influencers with greater than 1 million followers, but we might be able to make a difference. And then it gets to the question of knowledge, which is the first part of the slogan. Knowledge of what? I feel fairly sure that at the time this was written, knowledge was to be of the world. For a university, the world is what we study. For medical work, it is of all that can inform our care of patients. But that's only half of the equation. There's also self. And at the Temple of Apollo at Delphi, it's on the wall. Know thyself. And I think that's pretty important, not for necessarily everybody, but for people who wish to engage in healing. And I'll try to make that clear. So what can we know? And I'll try to show these in stories as we go forward. We can make our care better in encounters with individual patients through connection and negotiation. And when building better systems of care by valuing patients' perspectives and aspirations. But also we can know through coming to know our own flaws, which is uncomfortable and necessary. Not all people want to do it, but not an impediment to helping others. It's actually an asset. At this point, I want to turn. By the way, if you see that little magnifier in the right-hand lower corner, that's a signal to me that we're about to switch out of the personal to the scientific. If you see the little mirrors in the bottom, it means we're about to switch to the personal. That's the cue to me to avoid the fugue state. So we'll talk for a moment about homelessness, which is ultimately where much of my career has been focused. Homelessness has been in the public eye for a very long time. The picture on the left is a very young mayor, Dianne Feinstein, who eventually became senator, walking through a shanty town of San Francisco in the mid-1980s when I was in high school and then college. The picture on the right is a Caterpillar 289 D3. I'm sure you've all studied up on that, taking away a homeless tent in Washington, D.C. So this is always a topic where there is certain public uproar and upset. The federal definitions of homelessness are worth knowing because they help us think about the problem. Literal homelessness, when they say literal, it means someone who's on the streets or in the shelters or in a transitional program or an institution for less than 90 days after being homeless. So somebody's hospitalized, but they were homeless. They're still considered homeless when the count is done. Other federal categories exist and are used depending on the agency, including people who are fleeing domestic violence, children who are doubled up, and even in some laws, persons who are at imminent risk. I think when the word is said, this is what people think of. It's what the guy they saw on the street. I shot that photograph outside the hospital where I work just a week ago. And that is one kind of homelessness, rough sleeping. But there are other kinds of homelessness. The picture in the middle is from an early 2000s Time magazine article. A family, the Cochrans of Ohio, who had just been evicted and were probably in a motel with some support. And obviously there are shelters where individuals sleep, either with bunk beds or individual beds like this one in Rogers Park, photographed in the Tribune. One way to think about homelessness is if you do not control your own place, and I hope this works. But D was a patient of mine in the 1990s, and I interviewed and recorded him, and he described his experience even though he was periodically staying at his mom's house, but also at the Long Island shelter in the Boston Harbor. Hopefully this will play, and if not, I'll read it aloud. Come on.
If it ain't your place, your name on the lease, or you're written that fly, you're homeless, especially when you're living with somebody else, because they can put you on it anytime for any given reason. So I was homeless. I had places to stay, but it wasn't my place.
I had places to stay, but they wasn't my place. If you're shacking up with somebody where you don't have assurance that you can stay, you're effectively homeless. And this leads to the types of questions I ask when I'm on the wards, when I'm seeing people, and I'm curious about their housing situation, but I don't know up front. Where do you live? People say. In some instances, I have a sense that maybe the individual doesn't have a regular place. I say, well, where were you last night? It's an innocent question, and it's not a very stigmatizing one either. Is that where you've been? Is that where you've been staying? Person might say, well, no, that's not where I usually am. And then if they say, well, I was at this house, it was my sister's house in Hoover, Alabama, I might say, well, is that a place you know you can stay for as long as you need? They say, well, no, I'm just there now. Or she's saying yes, but I then have to move. Then you know you've got a housing situation that's going to affect, it's not just good to know, it's probably going to affect the discharge situation when you have a patient in the hospital. What if they need to receive IV antibiotics at home? How's that going to work? So we're going to turn back. If you look at these, see the little transition to the mirrors in the lower right-hand corner. So I want to explain, I wasn't planning to work on anything related to homelessness, but my first encounter with the question came up when I was a high school student. This is me as a senior. This group of misfits pictured on the C, in the C building on the second floor, is the journalism group at Homestead High School in Cupertino, California. We're all goofing off. People in the upper right-hand corner holding up what looked like beer cans. I'm standing there trying to look like an extremely nerdy person who's wearing extremely short shorts. It's kind of a fun group, but it was a serious paper. The newspaper we published won national awards year after year. This is one of them. I wrote the above the fold article on the attendance policy, but it's also marked up because we tore apart every issue for the flaws that were in it so that we can improve the next issue. And we took on very serious issues in this newspaper. This is 1984, part 2 of the abortion series. We covered all these things, some of which would not be permitted to be covered by high school newspapers today. So when homelessness hit the news, I thought, okay, we're going to take this on. And I asked Todd Jones to go with Todd Gray to go with me to San Jose to report on the homeless. And of course, I had no idea what I was getting into. And we were going to go to the riverbed next to the San Jose airport and to downtown San Jose. I said, I need a defender. This could get shaky out there. There could be violence, Todd. You need to be there just in case. So Todd, who was taller than me, had jeans, a leather jacket, and he packed a pretty large pair of nunchucks in his back pocket just in case things got violent. Of course, nothing like that actually happened. So I wandered out into the riverbed. I got a photograph from a guy downtown on the right. But in the riverbed, I met a young man who was pretty much my age, had a pretty rocky life situation. He was Latino. He had, I think, lost part of his family and was unable to go back to them. And I either did not feel comfortable photographing him or he said no. And I photographed what he was cooking. And that's the actual photo I took at the time. My intention was to report on the problem, but there's intent and then there's actuality. I did not report on the problem because I felt changed by the interviews. And so instead of writing a report, I wrote a reflection as an opinion columnist for the paper. And I sat there and I realized I was sitting in a very nice room in Sunnyvale, California, and there was this guy roughly my age out there in a field. So I wrote an article called Living in Streets, Bad Deal? And it begins, a man is dealing cards from a tall deck to 3 billion players seated at a large round table. Every player gets to play his hand to win or to lose. Winners, of course, are happy, and if not happy, at least they're satisfied. And they have a nasty habit, I go on, of attributing their victory to their own goodness and others' poor cards to their own mistakes. And I concluded, we realized that it was only a matter of chance that we ended up where we are, and someone else where he is, then we might think twice about the people we frequently ignore. And this was the beginning of a kind of knowledge of myself, a recognition of something that mattered to me. And I'd had, at the time, no plans to return to this topic in any career focus at all at that point. But I do want to come back to this question of why people are homeless. So when people talk about this, particularly if they're on the radio, podcast, newspaper, television, these are the things you hear. Lazy, drugs, the rent is too high, they choose to leave that lifestyle. All of these are explanations that seem to be jockeying for public attention in debates. But in fact, there are two types of questions why people are homeless. One question is, why are there more persons homeless here versus there, wherever you are, one city versus another, or now versus then? That sets the total number of people who are likely to be homeless. But then the other question is, given a certain amount of homelessness, why is this person the one who becomes homeless and not somebody else? And those are very different types of why. And I'm nowhere near the first person to recognize that there really are always two why questions. This same issue was explored in a study published in the 1930s by Edwin Sutherland and Harvey Locke, who were University of Indiana scholars, who assigned their own staff and paid homeless people to work in the shelters of Chicago to study 20,000 homeless men in the shelters to learn the life and the sociology and the experience of people who are homeless in Chicago's shelters during the Great Depression. And at the beginning of their book, they similarly said there's two accounts of why this is happening. One focuses on the moment in history to explain why there were 20,000 men in the Chicago shelters in 1934 and practically none in 1924. The other looks at characteristics of the shelter men in differentiation from the normal population. So when you want to look at who is likely to fall into that state, you have to think about their personal situation. And for any given question, any given person, ultimately the question is, can I hold on to my own place or have the benefit of someone who's committed to hosting me so that I will not be homeless? And that comes down to your personal assets and your personal liabilities. And those assets can be your job skills, your family's wealth, social support, the kinds of money that come to you, or rental vouchers. And your liabilities may include disability or addiction or trauma or poverty or mental illness. If you have very severe liabilities, but you are wealthy, it will be very hard to become homeless. It could happen, but it's rare. Those are essentially how one individual becomes homeless. And then all these things unfold in a given community in an environmental context, which is typically shaped heavily by the markets for jobs and for housing. Think about Chicago, of course, but also the coastal cities like California, New York. Those rents for a standard modest apartment are sky high compared to Birmingham or Houston. So that's kind of the why of homelessness. But again, I have to warn you, I wasn't planning at all and looking at this issue in the 1980s. But something happened to me in medical school. I went to medical school and I was unsure what I wanted to pursue. I was aware that I was showing off and trying to impress people. I was trying to learn differential diagnoses and rehearsing my presentations in front of a mirror before going on the wards. And I was like, I wonder what is this all for, really? What is the meaning of this other than performing to specification? And I applied to something called the Albert Schweitzer Fellowship. And I asked to go to their Africa program. And I did not say because I want to care for the Africans. And I did not say because I'm interested in tropical disease. All I said is, I'd like to figure out the meaning of my place in medicine. And I think this might be a good opportunity to do it. So there's a picture of me on the left on the equator in a small town called Ngomo in Gabon. I was there with a close friend, by the way, Saul Wiener, who I'll talk about later. And I think this was for high blood pressure. And there was a tremendous distance between my medical understanding and the patient's reality. And I just found that remarkably fun to travel. Whether they were discussing what the indigenous healer said they should do for the same problem, or there was a question about how to get that same medicine that they needed, or it was not even a medicine we had, but might be in the capital. The question of how to negotiate that so that the healthcare I provided was actually useful was enjoyable to me. And that's what kind of stuck in my mind as I entered residency, although I had no specific idea of how I was going to follow up on that. Because unfortunately, I still had a lot to learn. The story I want to tell you here is from my internship year and the end of my internship. That's actually where I met Adam Seafew first in September. I guess that was our worst month of our lives, or at least of residency, other than the fact that I like the residents and Adam in particular. But at the end of that internship, I got fairly good at the job of being an intern. And in the spring, probably June, my friend Kathy said, and we worked on one floor most of the time, 12 Reisman, that's the building you see there, the one that's triangular sort of. She said, the nurses were kind of snickering about you. I heard them talking. It seemed like they didn't like you. This is the end of my internship. So I was horrified. I don't know if I thought of this myself or somebody I trusted told me to do this, but I realized I'm going to be running my own team on the very same floor in a month from now, and apparently the nurses don't like me. I've got a problem. So I called the charge nurse and I said, I hear the nurses might have some concerns about me. I'm going to be a resident in a month. Would you be willing to ask them what might be the problem with me so that I can do a better job during my second year as a resident on the service? She said, sure, I didn't know anything about this, but I'll be glad to ask on your behalf. So a few weeks later, she called me. It was not a disaster, she said. They actually thought I worked hard and that I cared for my patients, and they realized that. But I was getting in the way of their efforts to help me because I was obsessive and controlling, detail-oriented, and supplanting them. So when a patient was in crisis, we needed the blood pressure, I would get in their way and try to take it myself instead of allowing them to take it. They want to help you, Stefan, but you're not letting them because you're trying to control everything. It's kind of hyper-conscientiousness on my part, but it was very annoying. And she said, but they did realize you're trying to help the patient. They know that. So at this point, I learned I could make an adjustment. I also learned, there's a typo there, that asking for insight was the right move. It's not only the case that I learned something. Turns out when you ask people, how can I do better? They're charmed immediately. They give you a lot of benefit of the doubt right off the bat. And if we step back a little bit, and this story didn't go away from my life in 1993, I can assure you of that. But there's this recognition that people who observe me might know something about me that I don't know, but I need to know in order to be effective. What the nurses saw really mattered. Others had already seen it before. It had affected me before. This flaw, it was a kind of intensity, a fear of things going wrong. Obsessiveness could also have aspects of equality. It could be something that could be used to good effect. Later, one of my bosses in University of Alabama, Birmingham, referred to this as KO, Kertesz overkill. So when I asked her for advice about writing a grant or updating a manuscript, I'd say, should I do the following or is it KO? And she'd say, don't do it, it's KO. And that was how we sort of filtered that stuff out. So you hire a professional coach. I didn't hire one for this, but I learned of something called the Johari window. And that's what this gets at. For each of us, there are things that are known to me, known to others, and those are out in the open. That's the upper left-hand box. There are things that are known to us that are unknown to others. Those are hidden things. Obviously, there's things none of us know. And then finally, there's that blue box in the upper right, which are the things that I don't know, but can be seen by others. Those are called the blind spots. And sometimes what we need is to move something from the blind spot out into the open. And we can only do that with the help of others. That's awareness. I'm perfectly aware that there are many professions where people do not wish to learn what's in their blind spot and don't necessarily have to. I just think it's helpful in medicine. There's a caveat I offer on moving flaws out of the blind spot is that we're rarely 100% blind to them. Even at an early age, we have a sense that something's not right. We might see something in bits. We might protest against it or defend against it. Our initial reactions to our own flaws might be quite unhelpful. But as the motto says, let knowledge grow from more to more. And that's what I hope to do with myself. I hope others who are thinking of entering medicine would do that too. And I believe we rarely shed our flaws completely. So at this point, I'd like to move onward to 1996, which will take us back to homelessness. At the end of residency, after doing a month as a visitor and seeing that there were several people from the Africa program who had taken jobs at Boston Healthcare for the homeless program, I thought, okay, I don't know what I think about homelessness, but I kind of like the people who work there, and it seems kind of interesting. I'll try it out. I still had an academic interest, but I just figured, let's try this out and see if it's something interesting. And right away, they gave me a very interesting job where I would work both at a mainstream clinic or a clinic near the hospital and also out in a shelter that no longer exists on an island in the middle of the Boston Harbor. And there were buses running to and from the city to the island with patients, not patients, residents, people seeking shelter or going to recovery programs on the island. Organization was highly focused on its mission. It was reasonably well funded. People could respond to tangible needs like clothing and housing and bus tickets and guidance to get into addiction programs. There were interdisciplinary teams. There was a street team that went out at night and found people on the streets. It wasn't my job, but the guy shown there, he might even be listening in today, is Jim O'Connell, referred to sometimes as the kind of Boston street doctor. Patients really trusted him. And there were empowered patients who became advocates for homeless healthcare, like Ellen Daly, who I'll talk about in a moment, but she's shown there, obviously, after she was homeless, advocating in Washington, D.C. There was also a lot of interesting medicine. I published this and another case of a man who I met at the Long Island shelter with this weepy, drippy, red rash on his face, collarbone area, upset stomach, and sour mood after a month of drinking pretty hard. And then him 2 months later, looking pretty good, same guy. He permitted the photograph, signed consents and all of that. And this was the second of 2 cases of pellagra that I encountered in the city of Boston, treatable, of course, with niacin and with just good nutrition. And those things were fascinating for somebody coming out of medical school. But what made the work of that organization so special came through to me, at least the beginnings, in a conversation with Dr. Jim. And this is in 1998, and it's roughly from memory. And I said, so Jim, what we do is assure access to care, right? He said, no, not exactly, not really. I said, I don't get it. It's Boston Healthcare for the Homeless program. I said, well, if you think about it, our patients are accessing lots of care in Boston. They can go to all the emergency departments they want. They were, I think, 4 within a square mile of each other. And what we do is quality of care, he said. We have a team-based system that assures care of higher quality. That's what we deliver. So that planted a thought in my mind in the late 1990s. And yet it was a thought that would be challenged. But what Jim was referring to is something that now we refer to organizationally as tailoring of the design of care. Tailoring is something that happens at the organizational level. It can include the types of services, the professionals who deliver it, the team structure, organizational culture, plenty more. We're still studying it. It can include outreach to the streets, the shelters and homes. There's people here from UFC's street medicine team. Hi. There are longer visits often, co-located addiction, HIV, or mental health care, response with tangible goods. I just heard the program, it's street medicine program here can give out phones, team-based care, many things more. But what could possibly go wrong if you're trying to uphold a model like this? Well, it turns out a lot. So here's an encounter in 2000. It's with a patient. And we had a medical director who was not Jim at the same organization. I met a man a few times at the shelter in Long Island and then in our clinic. He was in his 50s. He seemed dour. He seemed distrustful. He was focused on back pain and he wanted a lower bunk. So in my first few visits, I examined him. I gave him ibuprofen, an antidepressant, and I wrote the requested note for a lower bunk at the Long Island shelter. As it turns out, the shelter's leaders did not like my intrusion on the assignment of bunk beds, so they complained to my boss about writing this note. When you're young, by the way, this is very upsetting that people complain about your work. So our medical director hauled me in. She said, I don't really care about the whole bunk bed situation, but look, Stefan, he had high blood pressure. You didn't get a urinalysis for protein or check his eyes or treat the blood pressure. When managed care organizations review us, we'll be ruined. You have to do a much better job than this. It's not acceptable. And I promised to improve. I also thought there's something wrong with this picture. And I started thinking I might apply for a fellowship about now and not work as much for this medical director. And this gets to a larger question, which is that there are real risks to not measuring what matters to patients. The quality industry, which dominates our healthcare today, indexes on standard disease metrics. The metrics often don't match our patients' valued outcomes or context. And doctors don't like going against what's measured because think of how we're selected. The very way we are selected to become medical students is by asking what the specifications are and excelling on them as much as we could possibly do, including rehearsing in front of the mirror our presentations before rounds during our third-year medicine rotation, which I wish more of my students did, by the way, but I did it. Okay, the problem is that good care for vulnerable patients is at risk if their needs don't match what those quality industry metrics demand. So how could I, Stefan, make a case for actual good care? Because I'm an obsessive kind of guy and I'm worried about things going wrong. And if I'm not getting in the way of nurses, I'd like to actually make a difference. What could I measure to show that things might be better? And suddenly I thought of Ellen Daly, the patient I showed you in front of the Capitol Dome before, because I met Ellen at the Long Island shelter. And the story is one that she told to countless entering classes at Harvard Medical Schools for years thereafter, which is how we first met on a Thursday night at Long Island Shelter when she was dizzy and she had a gigantic thyroid, although she told me it had been tested at one of our prestigious hospitals and it was neither overactive nor underactive. But she was dizzy, bradycardic, and when she lifted her arms above her head, her heart rate went down and her blood pressure sank. Unfortunately, she died, but the story was right in her obituary. And I watched her and I decided the thyroid that was so big was getting in the way, pressing on her carotids and the baroreceptors that are located there. And she told me, I've been seeing doctors. They don't want to do anything about it. It's just gigantic. And I was angry. I said, what are these people doing? They need to get this thing out. So I paged people at night, Thursday night, at these prestigious hospitals saying, I'm seeing this patient in a shelter. You need to deal with this thyroid. It's causing the problem. In fact, that moved things along. They took the thyroid out. For a number of years, she did better as a result. And she credited me for the diagnostic acumen. But I think that what she also saw was that I was angry and that I acted immediately. And she praised me for this. She became a national advocate. And I began to watch Ellen's impact on others because while she praised me, she was sharply critical. And she had no problems walking into the office of the CEO of Boston Medical Center to tell her, you are doing things wrong for patients who are homeless here. You need to change how people are labeled in this hospital. You need to change how they're treated when they come in. And this is why she was elected the founding president of the National Consumer Advisory Board for the National Healthcare for the Homeless Council. She's referred to as the founding mother. And I said, you know, a lot of people listen to Ellen when they won't listen to me. So is there a Johari window for a healthcare system? So again, now instead of me, the window is the healthcare system. There are things about quality that are known to both the healthcare system and known to patients. That's in the purple box in the upper left. There are, of course, things unknown to all of us in the red box in the lower right. Things that we know as professionals that the patients might not know in the lower left-hand box, which is green. But then finally, there are aspects of quality that are known to the patients, but not known to the healthcare system. And that's what Ellen was a professional at getting across. And that arrow moving from the blue to the purple became 15 years of work for me. So it's not all the research I did, but it's a key part that I want to share with you. In 2007, as a young scholar at University of Alabama at Birmingham, which is where I wound up after marrying a Southerner who did not like Boston. I'll just let that sink in. It was a good decision to leave. Okay, in 2007, I proposed to compare homeless patient care experience ratings at clinics. Clinics that differed in whether they tailored their model of services. I had 5 in mind. And the hypothesis is pretty darn simple. The tailored ones would perform better than the mainstream ones. And this was in a period where surveys had been developed through a model that was sometimes referred to by a book called Through the Patient's Eyes. Patient-centered care was a popular expression. A lot of this became industrialized, as some of you will know, Amazonified. And I had planned to use an off-the-shelf patient experience survey, which is actually the progenitor of today's Consumer Assessment of Health Plans, the CAHPS. And my mentor assigned to me at the time, herself, previous Veterans Administration scholar Carol Ashton, said, don't do that. Don't do that. Don't take the survey that exists. You're interested in a very unique population. You have no idea whether the survey that they're using out there has anything to do with the concerns of your patients. Your project should be to develop the survey that actually tracks with what they care about, and then measure that, which of course was a good piece of advice, not only because it was worth learning what people actually cared about, but because that's how you win a grant. But just so you know what an off-the-shelf survey looks like, these are some of the questions from the current CAHPS. Question 10, in the last 6 months, did you contact this provider's office with a medical question during regular office hours? In the last 6 months, when you contacted this provider's office during regular office hours, how often did you get an answer to your medical question that same day? This is not a bad question. 15, in the last 6 months, how often did this provider show respect for what you had to say? I hope it would be always, but you can say never, sometimes, usually, or always. So these are not terrible questions. They're just a bit generic. It's not clear what they speak to, and that's where we didn't go. So my revised task, because of Carol Ashton's advice, was to craft a valid survey for what mattered to our patients. And this required interviews recorded and transcribed with 60 patients and expert clinicians across the country, recorded, and then studying over 1,000 pages of transcript and drafting hundreds of possible questions that we might try in a real survey of patients, and testing the most promising ones with 400 patients, and doing a bunch of statistical stuff, which is not my purpose to review here. So we started, in order to get this whole thing going, we said we have to start with some ideal constructs. What are the things that we can ask about? You don't even know what to ask about. You can't just ask, hey, what do you want? You could, if you're a true qualitative inductive script. What's quality? You could just start with that. But we started one step advanced to that. We took some items from a few reports of the Institute of Medicine at the time about what might define quality of care, that it's accountable, that it has continuity, that there's cooperation among caregivers, that it's accessible, that there's patient control. Think about that phrase, patient control. What do you think they meant? Evidence-based information flow between the clinical caregivers and the patients, coordination. There's more to it, but we had to choose 8. And when we did our interviews, a few more general ideas emerged from the patients and from the clinicians who took care of them. Homeless specific needs, the things that I just mentioned, like the phones and the clothing. Respect and stigma was an extremely powerful element that was leapt out of our interviews at us, because patients were used to being looked down upon. And substance use and mental health issues just had to be addressed. Okay, so those are the constructs. How do you develop an item? I'm going to try to focus on how we developed one item for one construct. And we focused on the most powerful quotations for every single one of these. And the way we asked about this idea of control, I hope you noticed control was something the Institute of Medicine, they suggested patients should have control in their care. So we asked patients and experts, what does it mean to you to have control in your primary care? Is that different when someone is homeless versus not? I'm going to share 3 answers from patients. Control means to me like he would be a puppet on a string. If I had control of anybody when I was drinking, I wouldn't be here today. I'd be dead. I think a primary care doctor should be a give and take. If I have any questions, he's going to give me the answers. If he has any questions, I should be willing to give him the answers. I should be straightforward with him. I'm sorry, it's all gender specific. That's their language. Honest with him, not try to connive different medications from him. And if I do that, I hope he would see through me and act the way he should act with my best interests. So this is remarkably nuanced and remarkably different from what we thought walking in. So we drafted a survey item, and for purpose of keeping our survey simple, there was no skip patterns. Every single item said, please indicate how much you agree or disagree with the following statements about the person or team who provides your primary medical care. Just your best guess. And one of the items mapped to control was this: if my primary care provider and I were to disagree about something related to my care, we could work it out. So that was our attempt to map to the nuance. There were several more items we tried. I'm just not going to show them all to you. This is not primarily a research talk, but I wanted you to see how we approach the question. Ultimately, although we approached 11 different scales or constructs, when the statistics played out of the items that worked best, we had 4 scales. One pertaining to the relationship with the clinician and the patient, including the patient's perception of the primary care clinician's competence. So if a patient agrees with this, it's bad. I worry about whether my primary care provider has the right skills to take good care of me. It's a relationship issue simply because statistically it performed well along with communication, respect, trust, those kinds of things. Perceptions of cooperation among the people who take care of you was a big issue. There was a lot of frustration there. So agreeing with this is terrible. I have been frustrated by the lack of communication among my primary care and other healthcare providers. It's not good to agree with that. Access coordination clumped together statistically. If I could not get to this place, I think the staff would reach out to try to help me get care. And by the way, this item's written so you don't have to be homeless the day you answer it. It's written to cover people who are in homeless vulnerable. And then homeless specific needs. The people who work at this place seem to like working with people who've been homeless. This is one of many, but it kind of gets at these stigma issues. We published our first paper on this, comparing 5 clinics. There were 3 clinics where it was a little more tailored. One of them was Boston Healthcare for the Homeless Program, which was a highly tailored model, and the care was better according to these scales at the highly tailored one. This is obviously not a randomized trial. It's just a case argument that tailoring might make a difference. And we did obviously do everything we could statistically to control for differences among the patients in these clinics to try to address the fact that they could be different. Some might be grumpier on a given day and answer more negatively. We had measures for those things. But the 5-site comparison was insufficient because they were 5 very diverse places in 5 different cities, and one was not in the Veterans Administration. So how different were these communities? And maybe it was just the place, or maybe the non-VA clinic was somehow better, or non-veterans versus Veterans Administration care. We were controlling for none of that. So was this really a study that had compared the tailored model to the mainstream, or were we just comparing people and practitioners in 5 places, which would then not support our hypothesis? Helpfully for us, in 2012, the VA opened 32 homeless tailored clinics all at once, called HPACs. And in any VA, the veterans experiencing homelessness could be found in both the HPACs and in the mainstream ones. So suddenly you have people who are similar to each other in the same community, some going to tailored clinics and some going to the regular mainstream primary care clinics. That meant they're more comparable. You still have to control for differences in the patients, but it resolves a lot of problems. So we sought to do a larger study, and it had 2 aims, and I'll only cover the first here, which is to compare ratings of care and tailored versus the mainstream clinics. And we also surveyed the staff and constructed a model to understand what tailoring is, which we'll not cover today. 5,766 veterans participated. There were 2/3 in those tailored clinics, 1/3 in the mainstream ones. They all had been homeless in the 2 years prior to the survey. 13% were homeless on the day of. And it wasn't in person, it was by phone or mail with a contracted group doing these surveys. I mentioned that here. It paid them. It wasn't doctors and nurses saying, do you like our care? Because that would bias the situation. We compared the mean scores, but what I wanted to use to illustrate the differences we found is something we called an unfavorable experience. On each of the scales, we could create a categorical outcome that it was unfavorable as opposed to favorable. It was defined by us as figuring out what number of items constituted the least satisfied 1/3 of patients for that particular scale. And it was usually 1 to 2 items where they would say they agree with something bad or they disagree with something good. And by definition, when you say we're looking for the least satisfied 1/3, the unfavorable rating should be about 1/3. The analyses also here controlled extensively for differences among the patients and controlled in other ways for differences between people who responded to the survey and people who did not respond to the survey. And as you might expect, the prevalence of unfavorable experience was lower in the tailored clinics. The green bar is lower than the white bar, and this is for the specific scale called the relationship to the clinical team. And it's not a gigantic difference, but it's a robust one, 27% versus 33%. We saw that across the board for all the scales we measured. But we got curious about another question, was, does the extra work of a tailored clinic matter most to an extra needy patient, someone who's in the most dire straits, somebody who we might get frustrated taking care of, somebody who's been on the streets, had a recent overdose, and is now asking for opioids for pain? Does the extra tailoring matter most for that person? So we defined ad hoc 4 vulnerabilities that we had measured in our survey: severe chronic pain, severe mental distress measured at the time of the survey, history of alcohol or drug overdose in the past 3 years, again through the survey. 7% of people had overdosed in the past 3 years. An unsheltered homeless experience in the past 6 months, because we knew from experience that the unsheltered customers were often the hardest to work with. Counting these leads to a score, 0, 1, 2, 3, 4. The higher the score, we would anticipate that unfavorable experiences would be more common for those with a higher burden of these vulnerabilities. And this is, again, just for the relationship scale. But what you see is from 0 to 4 vulnerabilities kind of tops out at 3 vulnerabilities. The percentage of people who are going to say that the care didn't do as well for them, whether it's the relationship scale or any other scale, is always highest in those who have the most vulnerabilities. There's lots of room for conflict when a patient has a rocky life, a rocky cognition, rocky emotions, not sure where they're going to stay that night, severe chronic pain, tendency to drug and alcohol use to excess. All these things we're not great at reacting to well in real time. We can be judgmental, we can get harsh, we can get snippy, or we can be presented with demands we cannot meet. And it can be frustrating for the patient. So those vulnerabilities affect how the patients rate the care. So how does the tailoring of the clinic affect that? What we're hypothesizing in the stats world is an interaction. I'm showing this to you in steps so that everyone can follow. Right now, the green bars only concern people with low levels of vulnerability. Right here, the solid green bar is a tailored clinic for patients with low vulnerability. 22% qualified as unfavorable experience. The stripy bar is, again, now a mainstream clinic, people with low vulnerability. So there's higher unfavorables in the mainstream clinic. The difference between 31% and 22% is 9. Okay. But when you look at the people who are high vulnerability, the purple bars, that difference is much larger. It's 28% to 47%, which is to say, the solid purple bar represents the impact of a tailored clinic for the toughest possible customer to serve, defined by having 2 or more vulnerabilities on our list. So that's who it mattered most for. That's what Jim O'Connell was talking about with me. So we can imagine that the relationship to a clinician is stressed when there's a heavier load of problems, and that tailored clinics mitigate problems the most for that group of patients. And we know in separate work that is in press that continuity of care turns out to be higher in tailored clinics than it is in mainstream clinics. The same patients keep coming back. So in this case, to an extent, enlisting patients in defining what was good helped to make the good things measurable. The Johari window for the healthcare system, my part of it was moving something on that little white arrow from the blue box to the purple box. Whether all of the healthcare system will embrace this in the immediate term and decide to do things based on that remains to be seen. Some have not. But that's the arrow. We're getting close to the end, but I think it's really important to offer a clarification. This came up when I was practicing and preparing this talk with several people. What if a patient's wishes are at odds with our clinical judgment? Could it be wrong to prioritize what patients tell us? Does that resonate here? Can you see how that might be a challenge? A threat, perhaps, to everything I've said? So there's no better place to express that concern than the history of the opioid crisis in the United States, where doctors stand accused, perhaps fairly, of having acceded to certain wishes, perhaps unwisely. And there's no better way to express this criticism to make it really hit home than in a quotation from a national expert from Stanford University, Anna Lemke, directed at me personally in the pages of Stat News 5 years ago. Because 5 years ago, I took up the concerns of patients with long-term pain who are being taken off their opioids against their will. And I said, this is wrong. And I pointed out we had no evidence that what was happening was actually going to protect those patients. And Stat News did a profile of me, but it being conscientious, they sought some criticisms. And Dr. Lemke says this, and I really want you to take this seriously. I am really worried that people like Stefan Kertesz, who is trying to champion patient-centered care, in some ways, are feeding into the same misleading messaging rolled out by Purdue Pharma and others, that not to prescribe opioids is tantamount to torturing patients. So her definition of patient-centered care, which I certainly do champion, is to do the thing that in some instances could harm the patient. I hope you take it seriously. There's some substance there, although, of course, we need to respond. Because please remember what our own patients, the ones we interviewed, said about that issue of control. They didn't exactly want control when they were asked in their best sort of interview mode, what does it mean to have control? They wanted a negotiated, collaborative relationship, and they didn't necessarily think their own control would always be good. And so we, and I'm referring to the people I work with, don't mean to create a system controlled by what patients tell us to do. There's a professional ethos for the doctors and the nurses and the physician assistants and others. But for individual care, we aim for human-to-human collaboration, face-to-face, because we're equals. So it should be collaborative. For systems, we need to design the systems to make that more likely. All of this involves approaching the patient as a fellow human being, always, as I said, an equal. The patient is not a problem list, but an equal. Much of this theme is explored in a wonderful book by a close friend and colleague, Dr. Saul Wiener, titled On Becoming a Healer, which he published in 2020. We issue a monthly podcast that explores issues like this in an ongoing way. It's in its 6th year. The episode coming out next week is on opioids, by the way, and is a cherished friend. So what's the meta story for this talk as we wrap up? We begin our lives not knowing some things about ourselves, including our flaws. Oh, yeah, good. Whether you wish to know depends on you. I'm very aware that in other professions, lots of people have no desire to learn about their flaws and they just defend against them. And certainly I participate in some of that behavior myself. But in the healing professions, learning these things matters. We gain by asking questions to move things in the Johari window out of the blind spot. We can be transformed by asking questions. Recall my 1984 foray out to the Guadalupe riverbed, where I couldn't write a report. I had to write a perspective because I was changed by the people I met. There was obsessiveness in my pursuit of the questions I pursued, and sometimes the obsessiveness misfired, and sometimes it was helpful. And I say we can calibrate our flaws rather than shed them. My aspirations for this talk were that you would know that understanding patients' hopes and experiences can ground our clinical work. That you would know that seeing ourselves and our flaws is part of growing in medicine. Some flaws can be calibrated into strengths. Any of us can make a difference step by step. Crescat Scientia Vita Excolator. I must thank a few people before I close out. In this image on the left-hand side are a wide range of collaborators and friends. They include people I work with in research, as well as that group photo of the clinical team at the Birmingham VA Homeless Patient Aligned Care Team. They include mentors featured in the middle, a range of them, probably not all of them, from Lachlan Farrow of the Albert Schweitzer Fellowship, Jim O'Connell, who I talked about, J. Lee Tucker, an addiction scholar, Carol Ashton, who told me to make my own survey, Susan Levine, a professor here, who actually was my first research supervisor, Lou Dell'Italia, my champion in the VA, Anne Fuqua, a patient with long-term pain, who alerted me to some of the things going on for patients, and Jeffrey Salmon and Katerina Kifa, 2 sequential bosses. And finally, on the right, of course, I have to thank my family, my father who's listening in, my mother, my son, Gabriel, and wife Alice, the 2 backyard sages there, Larry and Doug, who I've known since childhood, and Larry helped me with these slides, and our cat, Fleetwood. Thank you very much for listening to this talk. Where should I go? I'll stay here. Okay, I'll stay here.
Thank you very much, Stefan. That was wonderful. If I can open the floor to questions, if you can use the microphones, that would be great so people on Zoom can hear. We have a large Zoom audience, and I'm going to take some questions from the Zoom as well to chime in. Anybody want to start things off? Or should I take the responsibility? I will take the responsibility. Stefan, I loved the relationship, I think, from the very beginning, when you talked about reporting that this patient wants a lower bunk and you ignored completely his hypertension, and the relationship at the end where, people question if bowing to our patient desires and neglecting what maybe traditionally we should do as doctors is the right thing. It sounds like that's a continuing, tension in what you do. Is that true?
Yeah. Well, obviously, every single individual decision is subject to its own conditions. And those depend on the medical risks, the medical benefits, which is medical information, the context of their life, which is what my friend Saul has written about, their preferences, and the medical evidence. So it is a continuing tension. There are many decisions that sit in a gray zone, and it can be hard to figure out what to do. Often that does include opioids, pain medications, et cetera. Those are often a gray zone issue, not black and white. I think that a big key question is, when you're caring for people who've already been burned by the healthcare system or are distrustful of it, regardless of the reason, what are the steps I could take as a human being and in my actions that will make it more likely that I'm going to see this person a second time? There's no abstract good decision that involves, at least in primary care, it's rare that there's an abstract good decision that involves, I'll never see you again. I guess if the patient says, I plan to assault your staff, and you call the police, the right decision was to call the police, but we're outside the realm of healthcare there. With the guy who asked for the lower bunk, it's a little simpler to say, I think had he not found me credible, starting blood pressure medicines would have been a fool's errand, and he would never have stayed on them, and they would have had their benefit. For the criticisms regarding opioids is a rather elaborate debate that has gone on, most of which has shifted toward agreeing that the reductions that were made from 2015 to 2020 were terribly foolish and terribly mistaken and often proved harmful. But that initiation of those medications requires a good deal of care. And some would never initiate, by the way, because of the fear of risk benefit. I would, by the way. There's a question in the back, and then here, Dr. Chin, I think.
Yeah, hi, Stefan. Marshall Chin. I'm sorry Adam didn't wear his bow tie here, so you'd have like two of the Harvard, Boston sort of gentlemen showing their wares. Yeah. So, wonderful talk, and thank you for sharing so much of yourself and your vulnerability over the past hour. Very moving and inspiring talk. So I have an observation, and I'd be curious of your take on it. A lot of your talk has had what I would call a general patient-centered care lens, as opposed to, for persons with homelessness, more of an equity lens. I noticed, for example, like when you're designing your survey, you drew upon two reports from 20 years ago, the primary care report and then crossing the cog chasm. You didn't specifically mention the other big report around that time, which was unequal treatment. And you said you were surprised when a theme like stigma comes up, especially for a person with homelessness. I think a lot of things will come down to like power. When you do the deep dive of power, and power along a number of different dimensions, general power, right? And all the issues of power that come along with identity and then structures. I mean, you talk like your high school slide, very early on, you talked about structures and the role of structures, and then you sort of left it during much of your lecture talk. So I'm curious, because my understanding of like your work, and I admire your work, is that you do have more of an equity lens than you portray in this particular talk.
Am I hiding an equity lens? Oh, go on.
Yeah. But your overall framing, I would put in general patient-centered terms, which has value, but I don't think it's as powerful as if you explicitly add then the equity lens on top of that.
That's an interesting question. So I probably have mixed reactions. I did use, so at the personal level, at the end, of course, I spoke about the fact that we're just equals. So in some ways, I guess one could read into the word equal to equity. It's also true that the way that my work has evolved has usually been along the lines of, mostly, if we say we want to do a good job for people, how do we do a good job for people? Which is different from saying we're doing a bad job for these people because they lack power, which might also be true, by the way. But it's true that the way I frame those questions up has been more like, how do we do this best possible job? And you could argue, and you could probably accuse me of sort of, in some ways, avoiding a political element there. But that's not quite how I got there. I just got there with, how do we right the wrongs? And I thought the best way is to privilege a voice like Ellen's. So I think implicitly, when you choose to listen to people and take their voice and make it a powerful one, or at least let it guide what you do, you might be implicitly addressing equity, but it isn't the same kind of robust social critique that I have seen from other scholars in a variety of fields, but certainly including the homeless field. And I think that that's an important point. One thing that I would acknowledge is that it's relatively uncommon that I've published papers that compare the experience of homeless and non-homeless patients. It's occasional I've co-authored those. We found it's typically worse, but that's not a surprise. The other thing that kind of comes to mind here is that where I think about, usually the way I approach the equity question is, what did we say was the good thing we want to do, and why are we not doing it? And the strongest example there would be in situations where I saw malfeasance. And at one point in our life in Birmingham, Alabama, I observed that the federally funded healthcare for the homeless program was making it very hard for patients who are homeless to be seen, and gradually prioritizing patients who had insurance and homes in a separate clinic from those who were homeless. And I did a series of papers on that, largely to draw attention to malfeasance. But I would say it's fair game to say that that the work you've seen from me doesn't that doesn't rise to or doesn't amount to a political view that society has misarranged itself, except you kind of see the resonance of it in that high school column and the fact that I continue to work in the area. Thanks, Marshall. Dr. Seafield, and then Dr. Serrano.
I'll chime in with a question from the chat. This is from Zhang Wukban. Thank you very much for an interesting talk. I found the part on measuring what matters to patients especially inspiring. My question is related to this. How accurately or fairly do you think current research priorities on the health of people experiencing homelessness reflect the priorities that matter to these people? So I guess, are we sort of coming up with our own priorities while our patients have different priorities in the homeless population?
So I think that there are political moments where agencies announce this is what we're interested in because it's the buzzword of the moment. And often enough, those things do matter. So I would say like a whole bunch of opioid homeless stuff rose in the 2015 to 2020 era. That I don't think that people who are homeless were consulted about that. So it's a fair question to ask, well, what would they have said? It seemed reasonable. A lot of our work was partnered with the National Healthcare for the Homeless Council. And so we defined our own question, which meant that we weren't responding to a specific request for proposals. We just said, based on clinical work and consulting with the council, which has its own consumer advisory board, this is the work we want to do. And luckily, we found favor with funders for that. At the current moment, it's, and obviously I'm not representing the VA, but you'll see if you're looking at federal declarations about homelessness, a whole bunch of it combines two things. One is a focus on addiction, recovery, and the idea that clinical matters and clinical services will resolve homelessness. The second is really a kind of a public dispute about not wanting to see people are homeless. It's very hard for me to imagine how to do research on the second matter as a healthcare provider. People want to have an argument about who they can see and not see. That's really truly just in the realm of politics, not for me. If we're talking about recovery, I actually think that could be an important issue because over the years, I was worried always that our housing interventions didn't address the clinical needs of the populations we were housing adequately. And that as much as I did separate research on housing interventions and the value of those, we also pointed out that people need a lot of help once they're housed. Even there's this book about Dr. O'Connell. In the book, there's a lot of people who get housed and they have a terrible time in it. So did the people who are homeless specify that that's what they want studied? And the answer is, I don't think so. So I would love to see perhaps even stronger consultation with the most powerful groups that speak for people who are homeless, the National Coalition for Homeless Veterans and the Healthcare for the Homeless Council. Dr. Serrano.
I was struck by the fact that when you go on rounds, you sometimes or many times ask your patient, where did you sleep the night before? Are you homeless? And just having come off inpatient not too long ago, seeing 20 patients in 2 hours, I can't say I've ever really asked that question there.
I usually start with, where do you live, by the way?
Well, I'm here on the south side of Chicago. This is not an uncommon scenario. Yeah. And it does come up during our multidisciplinary rounds. And we find out that someone's in a shelter or homeless or sleeping on the bed of a friend and don't know how long they're going to be there. So I guess my question is, should we be incorporating this more into our daily practice? And more importantly, when you do find that answer, what's the next step? What do you do about it?
So if you're on rounds with the team, by the way, and you're the attending, you got a few minutes. The team wants to move. They've got to get to the next patient. Hi, how are you? Great to see you. Just make sure I understand why you're here. So we're going to have to get a little clinical history if I didn't see them the night before, but I usually do. And then I'll say, in the military, in VA, what branch of the service are you in? I always ask that. Okay, Marines, Semper Fi. Then, where do you live? Oh, you live there. Is that your place? Yeah, it's my house. Okay, we're done. Onward. But they might say, no, I'm at my sister's. Oh, can you stay there? I'm not sure. That's it. On rounds with a team, I'm not likely to go much further because we got to get to the next patient, but I'll just say we've just flagged an issue. One of us will have to go back and talk a little further and then discuss with social work if that's going to affect the discharge plan. That's all I need to figure out right away. Now, if I'm in an outpatient primary care, it's a whole different thing and I have more time. I often don't say, are you homeless? Direct. unless I'm working in a homeless shelter, in which case I think it's kind of a natural question. And then the person sometimes says, no, I'm not. I'm here for the night, but I'm going to be back at my place tomorrow. And, okay, great. But otherwise, some people are really thrown off if they're asked, are you homeless?
Thanks again for that wonderful presentation. So like a two-part question, both are relatively focused. The first is that we know that over the past 15 years, 2 decades, not just unhoused patients, but patients in America in general are less satisfied with their care and they trust their physicians less. So the first question is, do you think that this is specific to unhoused patients, or this phenomena and meta theme is pertinent to actually all the work that we do, regardless of which patients we're caring for? The second one is just a question about terminology. It seems to me that both in your personal path and in the sort of experiences you've had in the clinical environment, what you're saying is that routine expertise is insufficient. We need actually adaptive expertise to be the
That's
clinicians that are what our patients need. And so just your thoughts on those two.
So the first thing you pointed out is that, and I didn't actually know there was statistical studies to show that there's rising distrust of medical professionals, although that would align with rising distrust of expertise in general. I think, and I hadn't fully realized there had been specific questions about the medical profession in that, but it makes perfect sense when you say it. When we developed our survey, I did think, a lot of the questions that are coming out of detailed interviews with patients who have been homeless would also work for people who are perfectly fine, but they also don't necessarily feel that the person who sees them understands what's going on in their lives or would reach out to them if they couldn't get to care. And they might want to have that be part of their care. So I do agree. Many aspects of what we worked on in this specific realm, that is my experience, people who are homeless, actually should have some mapping beyond that, but that the particular questions might need to change. I've never tried to adapt this for, say, middle-class adults with severe mental illness who also need primary medical care and who actually are at high risk. If you have schizophrenia, you have higher risk of multiple medical diseases, and how would care need to be transformed for them? So I think that's legit. I would love to see that happen. I don't know if our funders will, but that's what I care about. The other thing you talked about was adaptive expertise, and I agree. I think the movement within homeless healthcare, the idea was always we want to equip everybody who sees patients who might be homeless to be ready to respond, but we also would like there to be some special expertise without trying to create a specialty or God knows what. But there's a little bit of the vibe of what the geriatricians did and those who are sometimes focused on homeless healthcare, except that since anybody works in an emergency room or hospital is going to see people with this experience, it's helpful to be sort of ready for these variations in life, whether it's homelessness or just unsettled homes or family disruption, which could be happening for many different reasons. I like the word adaptive expertise. I'll underscore that sometimes the best adaptation is by asking a person in the same unit as you to help figure out what to do with the patient. Remember the story about the nurses where I didn't let them take the blood pressure? I mean, when I'm in clinic now, if I don't know how to have a conversation with a patient, I'll just turn to the nurse. I'll say, do you think you can talk to this patient better than I can? Because I'm willing to sit there and have you talk this through. And then adaptive expertise is you do it and I'll be here. Yes, in the back. Oh, thanks. Yeah, come to the mic. That'll help the people on Zoom.
You showed about complex cases, more prone to some breakdown, right?
Yes.
In the trust. That's the sort of training dilemma we have in the emergency department.
Yes.
Maximum problems, everything in the red, substance abuse, psychosis, threats of violence, history of violence. And the interview, there's no interview. There's no relationship.
Yep.
I'm wondering, so any thoughts about where do we have some space in that situation as a clinician to restart something, even if it's a minimal interview, as opposed to the, no, I'm not suicidal, screw you.
So I wish I had Dr. Kelly Doran of NYU here with me, because she's an emergency room homeless healthcare expert, and I would like to hear her answers. Speaking sort of in her absence, Obviously, there are sometimes just acute psychotic issues that have to be managed in some blunt force way, and sometimes against the patient's will. But if setting that aside, one of the objectives I would have is in a situation where there's no trust and the person might just blow up at you in a moment. I've had somebody scream at me that I was an effing redneck. What with me wearing the bow tie, by the way, I was like, whoa, wrong term. I got a bow tie. I'm a Jewish guy from California. Am I really? But no, I think that the first question might be along the lines of, is there a need of yours that we might be able to help with today? Or is there anything that we can help with? And if you're next, is there anybody you know already who we should reach out to help you in this situation, so that when we develop a care plan, it's something that you actually believe might work? I also think if somebody's really hostile or just in a different space, I would take some time to let their emotions wash over me a little bit, sort of make sure I've taken my own temperature and not reacted to that in real time. And then said, okay, a lot's going on. It still comes back to, there's a lot going on. This is rough. Do you think we can can I help a little today? How could I help a little bit? And even if the patient says, no, you can't, you're useless. In fact, you're just as useless as the last one. The fact that you said those words, how can I help a little today? Could I do that? Maybe they'll remember that the next time they come to the emergency room and see the same face. You could be thrown out. Yeah, and it's really, I've had lots of learning on this issue, both from my own patients and from this podcast we do, that the patients don't owe it to us to make us feel better about ourselves. We can have some negative moments in our own heads, and usually that's information that we can use to think about a problem. Just don't leap to any conclusions. Yes.
Thank you so much. This is really wonderful. I think I'd like to look at the lens where you look back at yourself.
Yes.
What's your advice for people choosing an uncommon career, right? You chose something that most people didn't want to do at the time you did it. And you developed this incredible way to now address the doctor-patient relationship with the homeless population. At what point, what did you do to kind of keep your own peace around, I want to do this? I'm interested in meaningful careers for physicians.
Well, I mean, I'm still a bourgeois person who was participating in mainstream systems, meaning I knew myself well enough to know that I wasn't the person. There should be a person who can open up a brand new clinic in rural Maine, or their own clinic on the streets of San Francisco that is independent from all others, I guess. I wasn't that person. So the first thing is to know yourself and know what you can do. And then it's a good idea to push the limit of what you can do, but you can't violate who you are. I always felt that I was taking paths which involved a bit of experimentation, a bit of something that respected my passion and what I cared about. I also felt like they were fairly safe steps. I was still, that Boston Healthcare for the Homeless program was linked to 2 academic centers. It felt like a very protected laboratory for me. There were still ways in which I could participate in grand rounds or whatever and learn. If I had been a more adventurous sort, that wouldn't have been the step I took. So I think if you're slightly passionate, but you're slightly nervous, you can find a little bit of a middle ground. And I always took the view that I don't need to do exactly what my passion is. I need to steer within 20% to the left or right. As long as I'm between 10 o'clock and 2 o'clock of what I care about, it's close enough, because that also allows, in my case, making a living and being able to negotiate having a marriage and a kid. But that's just who I am. So I think a person has to have a high level of respect for themselves in terms of making the choices. Yes. Oh, Tyler in the back, president of the University of Chicago Fencing Club, which is my favorite sport.
Oh, thank you for plugging the club in. Thank you so much, Dr. Kertesz, for that presentation. I think I had a question about the implementation of like your view of what tailored care can mean. I'm a TLC volunteer here at the hospital, so I talk to a lot of patients that are in inpatient rooms. A lot of them, they've been in the hospital for multiple days. Sometimes they're jaded with their nurses, and they sometimes display a lot of frustration. But I think I have a lot of conversations with them, and I'm not a medical professional at this time, so a lot of the conversations we have are about everyday things, about how their life is in Chicago, how their grandkids are doing, things like that. And I find that just by like the spreading activation of them having a positive experience with someone affiliated at the hospital, not even a healthcare professional, they feel better towards the healthcare system writ large. And I feel like that can sort of constitute as a form of tailored care. So
Yes.
I was just wondering, in your experience, what is the role of like non-clinical interactions or like non-medical professionals affiliated with the hospital and their interactions with patients in delivering tailored care?
I think it's pretty important. I obviously I hadn't given it formal thought until you just said it, but what came to mind is I've sometimes had moments when I was on rounds with the team at the VA, and I walked out of the room feeling depressed. Actually, I was in the room feeling depressed because I couldn't even crack a smile on a patient's face. And I was like, they wouldn't react at all. And I was like, okay, we have nothing, we're accomplishing nothing. And I sometimes would just say, would it, in our professional world, I would say, well, do you think it would be helpful maybe if the chaplain came by, would you like somebody else to come by and chat? And some patients say no way, but particularly chaplain if they're not religious. And of course, clinical chaplaincy is a profession, to be clear. But the idea that somebody needs to be seen as a human being and treated like a human being as an equal, in a way, we should have people do that who are also called doctors. But we can't do it all alone. And it's really helpful just to be a regular person, even when you're in a hospital. Gets back to the idea that when you're sick, you adopt the sick role, which is something the sociologist Talcott Parsons wrote about back in the 1950s. And yet, I don't think people come out of the sick role unless they also have this access to the human role, which is not the sick role. And you're partly offering that. So I'd love to see that happen more, even at the hospital I work at.
Stefan, I would add, and I know you had this experience, when I rotated with healthcare for the homeless, the first couple of things you did was help people clean their feet and soak their feet, right?
Yeah.
And it was that these people don't need doctors to begin with, right? And this sort of gets them comfortable with the setting and the situation and the people. And those are sort of the, almost extra clinical care that's so crucial.
Yeah. I think the washing the feet is pretty important, particularly if you think about the model of Jesus, right? And I'm saying this as a Jewish guy, but I think that's a very powerful model. And I also think it restores the sense that we're in this together.
Well, at this point, let's thank Dr. Kertesz again for a wonderful talk.
Thank you for listening.
Before we close, however, we have a few minutes that I would like to ask the members of our Board of Advisors to come to the front of the room to give a few comments. So Drs. Aurora, Cohen, Dershel, and Rubenstein are with us. We'll ask them to come to the front. And as they're coming to the front, let me just briefly introduce them. Dr. Vinnie Aurora was appointed in 2022 as the Dean of Medical Education at the Pritzker School of Medicine, joined our board that year as well. Vinnie is the Herbert T. Abelson Professor of Medicine here at the University of Chicago and a 2014 appointee as a Bucksbaum-Siegler Institute Senior Faculty Scholar. Dr. Jordan Cohen is the President Emeritus of the Association of American Medical Colleges. He served as president for 12 years, also a former colleague here from the University of Chicago. Dr. Doug Dershel is professor and chairman of the Department of Orthopedic Surgery at Baylor University College of Medicine since April 23. Prior to his president role, Doug served as the inaugural chair of the Orthopedic Surgery Department here at the University of Chicago in 2013 and was named a master clinician at the Bucksbaum-Siegler Institute in 2014. And Dr. Arthur Rubenstein served as the chair of medicine at the University of Chicago from 1981 to 1997. He was then the dean at the Mount Sinai School of Medicine in New York City, then moved to the University of Pennsylvania as executive vice president of the University Health System as dean of the Perelman School of Medicine for many years. These are just four of our distinguished members of our board at the Bucksbaum-Siegler Institute. And would love to hear some of your thoughts today on both Dr. Kertesz's talk and where you see the future of medicine going in the Bucksbaum Institute. Vinny's on the end. I'll ask her first.
Okay, thank you so much for having me, and thank you for the wonderful keynote, and congratulations on the honor as well. I'm just gonna say that I've been thinking a lot about mentoring recently. As many of you know, my own mentor, Dr. Humphrey, passed away earlier this year. We'll be honoring her legacy. She was a prior board member, inaugural board member for the Bucksbaum Institute. And what really struck out to me from the talk actually was the power of mentoring and sort of the acknowledgments, and even from your time at UChicago as an undergrad, these experiences that you had, and that you remembered, the survey, not doing the survey, and working with actually Dr. Levine, Professor Levine, whose daughter actually was a Bucksbaum student. So yeah, so bringing it all home together, I just thought that as somebody who works a lot with students and residents and think a lot about mentoring, it was just really wonderful to hear about how mentoring has influenced you. And I'm wondering if you can reflect on some of the mentoring conversations that you've had possibly with students and residents interested in this work. It's very challenging, or working with patient populations like this. I think these are challenging times. And so we as mentors need to really help people think about the long road and the path ahead. And so anyway, those were just some of the reflections that I had. And in terms of the question about where we should be taking things, I think the Bucksbaum Institute is this amazing ecosystem of people all the way from, starting their careers, thinking about careers in medicine, to medical students, residents, and then up the chain to the most senior faculty and professors, emeriti. And I think there's so much to be learned from each other. And so that's maybe something we could think about exploring, is the power of mentoring in that landscape. So I'll pause there and say thank you for having me.
Dr. Cohen, thoughts on today's topics and our board meeting and symposium?
Well, first of all, I want to congratulate you on the wonderful talk. You really have deepened my understanding of patient-centered care. It's really a very important concept. But what leapt to my mind was something we talked about at our board meeting today, and that is the influence of artificial intelligence on the future of medicine. And it's going to be in every aspect of what we do. Hard to predict exactly how it's going to impact, but I'm curious to know what you think about how artificial intelligence can inform the kinds of things that you're worried about and thinking about in terms of bringing the individual patient's experience and their lifestyle and their wants and their desires and their needs into the forefront of the care. Is that something that we can deed to artificial intelligence, or is that going to be something that's going to be inevitably retained by the human connection that we have with our patients?
On. Okay, I'm turning this on. So thank you, Dr. Cohen, and thank you, Dr. Aurora. I'll comment briefly on both. With AI, I am very worried that there's no way that an AI agent can make me feel, it can be a fellow human being to me. I don't think that really sits within the realm of the possible. I've been very curious if it could capture the information that might matter to my care. I'm worried that it can't do it from medical records because we take terrible records. Now maybe in the future, could AI make those records more reliable in some way through recording of a visit? That's a fair question. But right now, if you're trusting what was auto-templated by a doctor who then checked a couple of additional boxes, or a nurse, it's not the right information for an AI agent to decide what to do. Now, the person I pin my hopes on is this colleague I mentioned 4 times during the talk, Dr. Saul Wiener, who's been looking at whether AI could be used in healthcare systems to capture elements of the patient's life that might be important to make the right clinical recommendation, even if those things are not medical, but rather context of their life, social things as well. And what I'm hearing is it's a mixed bag, but it might still be on the horizon. But in terms of helping someone understand that they are welcome and that I am not better than them. That has to come from a human. I'll touch briefly on Dr. Aurora's comment with mentoring. The two things I try to emphasize to people are to try not to imitate me, meaning I want to offer things or lessons or ideas that people can use, but there should be no thought in your mind that the goal is to be like me. The goal is to be like you. And particularly because I've become a researcher, and I know that that's respected in academic settings, I often say, don't assume that research is what you should do just because I wound up doing it. I'm still ambivalent about doing research, and I'm into it for 20 years. The question is, what would work given that you have a life before you? And I usually say something like, it's a marathon, not a sprint. So think about what you can actually sustain.
Dr. Dershel is one of our newest members of the board. Welcome back to the University of Chicago. Your thoughts on today?
Thanks so much, Matt. I was struck, and in a sense, far broader than just as applied to homelessness, with your concept and your phrase around patient control, and how that really meant to patients that they want collaboration in care and in care decisions. And I've become, no, I haven't become jaded, but I get upset with my own colleagues. I managed in orthopedic surgeons for far longer than I probably should, but they love to talk about control. And maybe it's true of other medical specialists as well, but orthopedic surgeons love to talk about control. And I can tell you, when they talk about control, they don't mean collaboration. And I think that's what came to me. And I think this is an important thing. And I'm going to start doing this as well. Whenever one of my faculty or one of my colleagues come to me about, I can't control this, I'm going to talk to them about collaboration. And they usually mean it. They mean it in all contexts, but they mean it specifically around patients as well. And they don't want that sense of equality. They want the power differential to remain so that they can impose their will on the patient and move on to the next one without truly listening and collaborating. So thank you for that.
Last but not least, Dr. Rubenstein, mentor to many of us, including myself many years ago. Your final words on today's symposium.
It's a big job to do, but whatever. It's a great pleasure to be back here. I always enjoy coming, and today was no exception. Things look really, really good at the University of Chicago Medical Center, and that gives me great pleasure. And as Vinny said last night, I was at the service for Holly, done by the Macy Foundation, and it brought back all kinds of memories of just what a fantastic person she was and the influence she had on this institution, and how one person can make a huge difference in all kinds of ways. The other point I'd make is the Bucksbaum Institute, after some 14 years, has blossomed into really an amazing organization. Every year there's something new and exciting. All our suggestions, they probably do ahead of time, which is reassuring. And the movement this year under Matt is really impressive. And it gives me just enormous pleasure to see what kind of impact a relatively small school can have in the wider world which it impacts. And maybe it would be appropriate to also pay tribute to my good friend Mark Siegler, sitting there, who's now named with the Bucksbaum Institute, the Bucksbaum-Siegler Institute. Mark and I go back many, many decades, and I won't tell you all the stories that would make you laugh or cry or whatever, but he was always a visionary. And between the Bucksbaum-Siegler Institute, the McLean Institute, and many of the innovative things that arose out of this great school, Mark was one of the most important leaders. So I'd like to just say, Mark, you should feel very proud of all that you've accomplished as well. So in summary, you should all feel really great to be here. It's a wonderful institution. Dr. Kelsey's talk was inspiring, as many people have mentioned, and I also certainly learned a lot from it. So I wish you all well, and it's a great pleasure to be here. And I also want to thank Matt for all his leadership. Thank you.
Give a big round of applause for our board, for Dr. Kertesz. Thank you for all the work you do. Thanks for being here today. And we hope to have interactions with all of you very frequently in the future. So thank you, everybody.